Well, good afternoon, everybody. This is Stephanie Hall, and I'm with the ESRD NCC National Coordinating Center. Just thank everybody for joining us today for our professional COVID-19 educational webinar event. As you know, these events are being held in partnership with the Centers for Medicare and Medicaid Services. The series of events feature guest speakers from around the country sharing how they or their organizations they are with are coping with COVID-19. Before we get started, I wanted to let you know that this call is being recorded and will be posted to the NCC COVID webpage within 3 business days. Next slide. So just a little bit about what the call is about. We talked about. We have a speaker, Dr. Saggi. We will get into a little bit more of his introduction in just a minute. The topic today will be about improving mortality outcomes in the dialysis facilities during a pandemic with early process improvements. All the participants have been muted upon entry, but we do want to hear from you today. So during the presentation, if you have questions for Dr. Saggi, we really encourage you to enter them through the chat or the Q&A panel. And at the end of the presentation, time allowing, we will answer as many questions as we can. Next slide. So as I said just a few minutes ago, we hear from different stakeholders and peers from the ESRD community who are adapting to the COVID-19 pandemic. They share examples and provide real-world strategies for facilities to use. And as you know, we put these webinars on twice a month, and they're on various different topics. Next slide. So before we get into our presentation, let me go ahead and introduce Dr. Saggi. He currently serves as the Director of Ambulatory Dialysis and Kidney Pancreas Transplant Program at State University of New York, Downstate. His primary research interest is to study the pathogenesis of kidney injury and the development of biomarkers to detect early onset of renal failure. Dr. Saggi was trained as a molecular biologist with a fellowship in kidney diseases and master's in public health. He has led multiple clinical trials at Downstate, advancing new pharmaceutical drug safety and efficacy. He leads the Clinical Trial Center in the Department of Medicine and trains clinicians, fellows, residents, and research staff. I'm pleased to announce Dr. Saggi, and Dr. Saggi, you can up to you.
Okay, thank you, Stephanie, and thank you, NCC, for giving me this opportunity. It is truly an honor to speak to such a vast audience. So I'm going to just dive straight into it, as you know, we all have very busy schedules, and I'm truly appreciative of the audience that is joining in today. And right now I can tell you that because of your commitment and because of your camaraderie and working together during the COVID pandemic, we all are pulling through. And I think there's one message I want to send today, and you'll see many messages in my presentation. And the first and the foremost one is that we all work together in this, and teamwork really plays a big role. So can I have the first slide, Stephanie? So I have no disclosures except that I'm also as End-Stage Network Region 2, I'm the Medical Review Board member and the chair now, and I actually don't receive any compensation. It is voluntary. I have no financial relationships or, otherwise attached with this presentation or in general. And which is shown in this slide. Next slide. So my objective is to, is basically 3. One, how did we rapidly implement process improvements during this COVID pandemic, and what did we do to support our patients and staff during a pandemic? The second mission in this presentation is to tell you all that early intervention implementation plays a big role. And then what we did in terms of monitoring what intervention steps we took to see that we are successfully curtailing the spread of the disease. And furthermore, we wanted to then go ahead and sustain that change and that we don't break down with all the interventions we are doing. The third mission that with this presentation is to share with you all what I did and our team did on patient and staff wellness and efforts to maintain safety during a crisis situation. So can I have the next slide? So my first question to the audience would be, but obviously I can't ask any questions now, is wondering why am I showing these two pictures? And yes, I'm from New York. The picture on the left is of New York City, Manhattan, and the picture on the right is Brooklyn, is where I work, although I reside in Manhattan, uh, and I commute. But is to show everybody is how congested New York City is. In fact, today I was listening to the news that it is the most congested traffic city in this country, and we are very neck and neck with Los Angeles. So, it's just to keep this in mind, and also to tell us that we were truly unprepared for that something is going to hit us. Can I have the next slide? So, as this is also a learning session, something that I want to share with my colleagues is what I do on a fairly regular basis is to see what's happening to the census. And this is one site anybody can go to. It's free. And here's an example of New York City consisting of, in 2010, our population had 8.2 million residents. It increased to 8.5 million residents with a growth percent change of 3.74. Now, Brooklyn is, fairly large borough. In 2010, we had about 2.5 million residents, and in fact, it's one of the largest boroughs within the New York City. And in 2020, we increased to 2.6 million with a growth rate of 3.74%. Now, you may wonder, why am I showing this? It's to get an idea of, surge building capacity we have to keep in mind should an event start to happen. But it also, I look at this because always I'm looking at, what is the incidence of CKD, what is the incidence of ESRD, how many transplants are happening. So some baseline I need to go by to give me an idea, and this is what I turn to. So I'm sort of setting the stage at this point, and one has to know where to look for what. So these are examples. One I'm suggesting as to what I was doing already before the pandemic hit. Can I have the next slide? So if one wants to look at more granular detail, one can, and one doesn't have to. But to make a comparison, New York City has, here's the population listed, and it's comparing to Los Angeles, Chicago, but also yearly how much growth rate has been happening. Obviously, 2020 it was minus 0.01% in New York City, but hopefully it will come back. It just gives an idea, are people migrating back and forth between states or what's happening? Next slide. Stephanie, can I have the next slide? Okay, so then I show the slide to ask our audience again, now where in the world are we? Obviously looks like an Oriental country, and it's those who recognized it will say, yes, this is Wuhan. And it has a resident population of about 11.08 million residents, a fairly populated country, and we a city within China, but we never expected anything to be coming from there, but it did. Uh, so, between Manhattan, Brooklyn, Bronx, the populations, are fairly close-knit, very large, populous states within a country. Next slide. Uh, so when and the while I was making this presentation, I thought the first thing I need to do is set a timeline as to what was happening, in order to give you all an idea how we started, sort of prior to the pandemic preparations. And some of the questions that may come up is, what insights we had, and I will discuss that. But on December 30, 2019, a Chinese doctor sounded the alarm, and the story goes that he was an ophthalmologist and he was doing cataract operation on one of the patients, and who actually had already acquired COVID, and she used to work in one of the laboratories where the exposure had happened. And being so close to the patient doing the cataract surgery, he acquired the infection himself. And then he heard from that same patient that there were other individuals who were sick, and he suspected a SARS-like outbreak was happening. And he, tried to inform the authorities, but he wasn't allowed to. And then subsequently, he died. But before his death, he did report the reports got out that there was an emergence of infectious agent. And the first time that this report got out was on December 30, 2019. Can I have the next slide? On December 31st, the Chinese authorities were already aware that some deaths were happening, but they didn't want to be caught, in hindsight, that they didn't report. So a day after his death, they reported, or the day he broke out, told the world, December 31st, Chinese health authorities themselves announced there were mysterious cases of pneumonia, and that they couldn't understand what this disease was. And it was rapidly spreading among several individuals. We don't know the details further beyond this, how many cases back then, but at least they made the first alarm. Next slide. On January 4th, 2020, World Health Organization started tracking illnesses in Wuhan. And they actually flew down there, members flew down there, and they started implementing, as you can see on the right-hand side, temperature checks across, across the public, and to monitor as to what is really happening. So literally 3 days after China makes the announcement, World Health Organization is there to support them. Next slide. Now, January 13, it wasn't clear up from the 4th to the 13th what was really happening, but Thailand became the next place where the disease hit. And then it started becoming clear after January 13th that this is likely going to be a pandemic. Next slide. And this is just to show that within overnight in Thailand, um, it became like a gigantic emergency room with lots of cases coming in, and the alarms were being sounded by Thailand also that this disease is highly infectious. Next slide. January 23rd, World Health Organization and China makes a determination to shut down Wuhan, and it's shut down. Now, people may wonder, what has this got to do with my presentation? But I'm coming to the point soon. Is I want to send a message that one has to be listening to the news channels of what is trickling down. Next slide. And on February 4th, as most of the individuals know, that United States shut down entry ports and imposes a lockdown for the individuals that are on these ships. They can't come out until they're very sure that there is no COVID-like illness with the passengers. Next slide. Now, so, we are sitting here in Brooklyn, and I don't know what is happening. I'm getting all of this news. Suddenly, many websites start to open, both nationally and worldwide, and reports become available for comparing what's happening between different countries and states. And I must tell you, as people who know me, I'm an early riser, and I'm always looking at these reports as to what is really happening in my environment. And I told my leaderships here, and I informed, and I was in communication with most of my administrators here, as well as the hospital authorities, and many of the dialysis folks, that there's an there's a pandemic happening. Reports are coming in, and and the patients are getting very ill. They're requiring ventilators, and so we'll have to think of planning, ICU beds, etc. There were discussions happening, um, and the fourth the fourth point that I have here is perhaps the most important one. Is whenever a crisis hits, we have to address it immediately. And one is creation of huddles and groups of individuals that can get together and start the planning process. So preparation of huddles is extremely important. Who will consist of the huddles is another question. But one of the things that, I was also involved in assisting the hospital and all is that, and alerting them with the papers that were coming out and publications from China and Italy, that ICU bed planning was absolutely important to improve this, to have the surge capacity. Um, PPEs, as most of us know, this was an essential component, and having proper training of how to don and gown are also measures we were already thinking back in January, and also learning how to keep an inventory. Also, because within even our Brooklyn healthcare system here, and the hospital that I work, each component of the hospital split up into different units of planning ahead of time, what preparations they need to make. And a report was expected from each department and divisions as to how are they planning, what they're going to do in the presence of this pandemic. Next slide. Uh, so I'm just showing you a pictorial of where I am, and we sit in heart of Brooklyn. We have a state hospital on one side and the city hospital across the street. And the question comes up is, when you're sitting in this environment anywhere as a physician, medical director, the questions come to your mind as to where do you begin, because it's such a big world and all these news are coming to you. And as a medical director, I can tell you the first thing that really was upsetting me was I really had to struggle what strategies to use as a facility that might or might not have the strong support of the hospitals nearby, because they themselves were struggling with what to do, right? So one has to strategize with whatever resources they have within their small domains. That's the key. And also resources are limited. I mean, let's be realistic. There are not obtained resources available. And I'll walk you through as to what we did in the next few slides. And eventually the message will come through. So these are the things that I was struggling sitting in the seat that I sit, uh, and relying on information pouring in. Next slide. So I'm just showing this as a pictorial representation, and this is more current, but back then our hospital was doing a lot, and I really credit them for doing this, where they started forming multiple teams. ICU, critical care, and they were going through phases, and there were several phases employed where faculty was being deployed and staff were being deployed. And a record was being kept also of this as to how we're moving through different phases. Next slide. So on March 14th, the first death from coronavirus was announced in New York City. Although the disease had already started in China, as I mentioned, towards the end of December. And so if the disease had started at the end of December, one has to think back. Now that we know a lot more about the disease, we can say what we want to, but one has to think back at least 2 weeks or 3 weeks. So maybe it really began sometime in November. And so this death in New York City was the first alarm that sent chills through everybody's soul that we need to do something urgently, and overnight everything changed. So, one of the strategies I utilized was that I wanted to engage the people I work with. So those are my stakeholders in the facility. And again, I have been brought up thinking of starting to do huddles, just like the hospitals do. I said we're going to have our mini huddles every day. And my first thing was that I did not want a death of a dialysis patient, period. Second of all, my second goal was that I want to limit if somebody turns COVID positive, and realize this was an era when we really didn't have, what test to use, how to do it. There was mass confusion. But luckily, given my molecular background, I said, no, I want to work with the PCR. And one of the things that I started doing was looking at who's doing what tests, what platforms they're using, and based on the background education I've had, I could pick the right ones. And I sort of spoke to my pathology counterparts and asked them, and I was constantly keeping up to date with them as to what platforms they're using. And I was a part of that discussion a bit, but not as much, because my focus was even bigger to trying to hold my dialysis population together and safe. So the damage control is what I have labeled was my mission. Um, and again, the only way to begin huddles is by creating small teams who understand and who can absorb what is really happening. Um, the the other point that I'm making is, given this deaths, the first reports of deaths that are happening, and then I was keeping listening to the information that China has been putting out and Italy was putting out. And I was already preempted that I've got to keep up with this knowledge. What is happening, what they are doing will help us if we do that. So, knowledge is very important, and getting onto the websites and listening is very important. And then to sift through what you want to do locally. So one of the places I turned to is CDC. We all turn to CDC now, but back then, I was already looking at CDC, what they had to offer. But more importantly, my local folks here know that I'm a partner with CDC Coalition for Infection Control. And that is, one has to participate and be willing to be a coalition. And as a coalition, we are like ambassadors of CDC, right? So facilities that are not coalition partners would be at a loss, and I highly encourage them to be partners. So that helped me a little bit because I could get some more clarity to what information is filtering in. And also, Department of Health has been very supportive of all the providers giving us information literally every day or every other day, updates on everything. And I have to thank the networks who really took on a hat and said, we have to work as a team, and we're going to have huddles. And literally every week we were having meetings so that each facility could say what they're doing or what is happening, so that awareness was created what to do. Next slide. Now, CDC offers guidelines and problems faced by dialysis facilities, but they're not there to tell you what to do. So what is a dialysis facility? What are our challenges as dialysis facilities? Well, we have 4 hours of contact time. The patients are sitting very close to each other in proximity. There's repeated exposure. There are multiple tasks staff are performing. There's rapid turnaround of patients and staff, and there's no respiratory isolation. So right away, I sensed we are a sitting time bomb for everybody contracting this, and my fear was so much going back in December itself, that I said, no, something needs to be done. So I just want to raise this, that as a facility, we are we're at a bigger threat than that was in coming out in the news. Next slide. Now, there are, as people who work in facilities, you know that there's contact exposure items in dialysis units are multiple, right? You could be having meetings, you could be testing blood sugar, you could be taking blood pressure. There are so many areas of contact. It's not one. So this is a challenge. Next slide. And just to give you what really happens for individuals who don't really maybe working directly with dialysis facilities is that this is an example of when a nurse goes to take care of a central venous catheter. Shown pictorially here is when a nurse goes to take care of a dialysis patient, she has to do hand hygiene, and then so those nodes, they're called nodal points, where points of exposure to an infectious agent can happen, right? She has to assemble her supplies. She has to go back and do hand hygiene. She has to don clean gloves, goes on and on. Then she has to scrub the catheter hub. Then she has to come back. I mean, just imagine, this is so complex. There's just one task that she could be exposed to anything infectious. Okay, next slide. But unawares to us. So we as facility who work in facilities are familiar with central venous catheters, but we were not totally prepared of trying to now know what are the other forms of disease transmission, and COVID being a respiratory illness, and droplet-borne illness. And this information started coming out a little bit later. But, as a physician, most of us were primed with the SARS epidemic that had happened a few years before. So I was ultra sensitive, and I was aware that there are more than contact exposure ways of transmitting disease. All right. So I just show this is because to this day, sometimes there is confusion as to how long the droplet lasts, and so on and so forth. We don't have to know that such details, but we have to be aware that there are different ways of spreading the diseases. Next slide. So, what matters in pandemics and what helps us survive is emergency preparedness measures. I think that is so critical. Um, and then the timeline for implementation. This is why I went through this, effort of putting the timeline for each one of you to see when the disease was spreading. The message is that one has to be a step ahead of the disease, right? So if the disease was starting in December, what did I do? I needed to tell myself I need to have started something in November, and I'll share with you all my early intervention that I had done. And I think more important is knowing all the critical nodes of where transmission is happening, and also disseminating the knowledge to everybody in the facility. everybody should be aware what is happening and how infection is being spread. So I think that's very important. Next slide. So one of the things, as a medical director and my administrators and my staff supported me is that I actually started offering, or our facility started offering masks to patients at the point of entry beginning November 2019. This is before the disease was announced. So what triggered me to do this? Flu, H1N1 flu. I was ultra sensitive to my population that, you know, may be refusing vaccinations to flu. And I'd said in the beginning that nobody walks into the facility until the few things are done. One, you are offered hand sanitizer to wash your hands when you come in and ask the three questions. Are you having fever? We were not measuring temperature back then. Are you feeling well? Are you not feeling well? Are you coughing, sneezing? And then we would offer them masks. And we also when the pandemic happened, subsequent to that, we created a mini isolation room at the point of entry. I show you these pictures of mask and hand washing. I had specifically insisted, and my team has insisted, is offering hand washing in the entry and offering of masks. So we started this in November 2019, unbeknownst to us that a COVID pandemic is going to be happening. All right, next slide. So subsequently, we did more implementation once we were aware and social distancing was created, even in the waiting area. As you can see, may not be the best social distancing, but sufficient enough that we were staggering the patients coming in and separating them. Next slide. So, this is fine and dandy, but then what did we do with data? I am a data person also, and I involve my biostatisticians, and I said, I want to know, yes, we started implementing this back in November, but what is the evidence that, we are achieving some goals that we want to, that is avoiding mortality and avoiding infection spread. So what I did was I sat down one day and burnt my lights out. I said, I need to create a questionnaire. And I did create a questionnaire, which I cannot share today, but I will give you a little synopsis of the questionnaire. And I said, I want to send it out to several dialysis facilities. They are, if they want to respond, well and good. If they don't respond, fine. I wanted to know, because hemodialysis units are clustered, we are close contact environments. I wanted to know what infection control measures they implemented and when. That is all I was asking. I was not asking them how many patients died. I was not asking them. It was a completely anonymous survey. And I will talk to you more about this survey that I conducted in the midst of COVID going on, because I needed to know if I'm doing step one, is it correct? If I'm doing step two, is it correct? I did not know what to do. So data gives me information. So 16 dialysis facilities responded to the survey, and I had sent it out to, over 60 or 70 facilities, and most of them were busy with the pandemic. They were not interested, and they didn't want to be bothered answering questionnaire. And the questionnaire was only 30. I recall 30 or 32 questions, and they were simple answers. And but you know to the kindness of the ones that responded, and this may be a limitation of the study. But we did find, first message was there was wide variation in number of COVID cases in each facility, all right? It could be varying from 20 to 60% of the cases being infected in a facility. And also the death rates were I had a sense of how many deaths were happening, because deaths were being reported. But so the first question was to me, why so much variation? Is it because is facility A doing something different than facility B? And my goal of doing this questionnaire was that I wanted to learn from the succeeding ones or the good ones, what were they doing? Maybe we can implement that practice here. And these were my challenges, that many facilities didn't want to share their practices for no clear reasons. But whatever information we got, we did an analysis, and this is what I wanted to show you in the next few slides. Can I have the next slide, Stephanie? All right, so as a synopsis, we asked, does your facility have an infection control preventionist? And then second, as an example, was when did your facility implement the wearing of masks by patient during their treatment? And the third question was, did your facility distribute education materials to patients during COVID-19 pandemic from March 1 to May regarding infection control education and social distancing? These are just examples. So there are many of the questions for yes and no, easy to answer. Only a couple of questions required as to when did you implement so and so, like wearing of masks or hand sanitizing, etc. Next slide. And so here was the way to interpret this graph is which is written in blue is when the first cases of COVID started to appear, and as an example, when hand sanitizer was implemented. Okay, so when you see a separation, that means that implementation of hand sanitizer early on delayed any occurrence of COVID-19 in your facility. So when you see these two separating, that means hand sanitizer at the point of entry early on, before when the first death was reported, made an impact that you didn't spread the disease in your facility. So as you can see on the right hand side, some facilities had only 4 cases. Some facilities had 30 cases of COVID, and it correlated quite well from the time of implementation of a simple thing like washing of hand and hand sanitizer at point of entry. Next question. So, and that came out to be the most crucial intervention, by the way. The second thing that we analyzed was masks. And there's a lot of argument even going on today. Should you wear mask? You're vaccinated. Should you not wear mask? Should you, what we found that, yes, although our facility was providing masks at the point of entry after they asked the questions, there was no correlation. And I think the reason was simple, is because they would wear the masks maybe in the facility, but once they go out, they take it out and they come back. So I think it was very hard for us to tease out whether mask provision was an essential component that prevented the occurrence of disease in new cases. Next question. Next slide, sorry. And the third thing was PPE provision. And there was a lot of friction going on in terms of PPE provision, resources for PPE, keeping an inventory of PPE, where to get PPE. And we had already implemented a donning and removal of PPEs in December, believe it or not, or early January. And then we re-educated them around in March. And it didn't correlate very well. And I think members know that PPE rules are easily broken, I think. And this is why we were not finding that implementing early PPE played such a role. But I'm not going to say that it doesn't. It does, but we could not find in our small study we did. Next slide, please. So what I actually found was, which is not coming out in the presentation very well, is infection preventionist role. To me, I think that is one of the most quintessential person in a dialysis facility to prevent infection spreading. So this lady is usually a nurse, and she plays so many roles. She is sitting there watching people come in. She's making observations. She's monitoring, she's educating patients, she's collecting data silently without anybody knowing what's going on. And this is why some people fear her presence and they behave more better. But actually, she's collecting the data irrespective of what you do, right? And so that we can go back and analyze as to, what intervention really worked. That's the role of an infection preventionist. And, when I joined the CDC coalition, that was one message loud and clear to me. When I came back from Atlanta, this was way before COVID, told my administrators and I told my facility managers, we need an infection preventionist here, period. And I asked my organization to support it, and they did. And we shared the hospital infection preventionist who comes, and she does a remarkable job of helping our nursing and staff educated, etc. Next slide. So, people will have questions. The study was small. And you want questions, statisticians will know it's called type 1 and type 2 error. Type 1 error happens when the sample size is so small and something significant might be missed. And type 2 error is when the sample size is too large and something insignificant may be avoided. So, it's how you interpret it. And the other thing is bias and response. When an administrator or facility manager gets the questionnaire, even though it is anonymous, they're usually extra cautious of responding, yes, they implemented. So I did not have such detailed analysis that I can provide you. Was there a bias in response? Of course, the refusal rate was high, and to this day I couldn't understand why. Why wouldn't facilities want to join hands and say, let's work together and let's learn from each other? And this troubles me to this day. And also, I have not done replication from other cohorts. So these are my limitations. But amongst all three interventions, I found giving hand sanitization in the point of entry and washing hands was the most important early intervention, a message I would like to send. Next slide. So next pandemic solutions. What else might work in next pandemic? So what I've learned is immediate information. So presence of good IT structure, access to websites, sharing of information is of quintessential importance, and also rapidly disseminating that information amongst all your stakeholders, patients, staff is very important. Um, the other thing is people need to listen. You've got to have a receptive audience. And the most important receptive audience has to be stakeholders. If the nurse manager, nurse in charge is not interested in listening to you, you're never going to get the message across. So you have to have the buy-in of them at every step along the way. And it is remarkable that what we did was all hands on team approach. So like I have a strong team of PAs that support me, and thank God for that. And if they had not jumped in to help, I don't know how I would have done all of this. And I must thank the leadership support of the hospital that has stood by us no matter what, because when we needed supplies and resource limitations, we could approach the hospital. Now, I understand there are facilities that may not have the hospital support, and they are in a bigger challenging position than I was to get the support I needed, whether it be access to information, whether it be access to different huddles and what's happening, so we can learn from each other. Next slide. Stephanie, next slide. So what's next on the horizon? One would worry about vaccination, right? Or repeated testing. Next slide. So a question comes up, is vaccinating the best strategy? Now, remember, I made this presentation quite some time ago, and then I refined it, but I was collecting data on vaccination. I knew from the beginning, yes, vaccination is the best strategy, but there will be always individuals who refuse. there will be always individuals who don't mount enough of an antibody or a T cell mediated response. There will always be some individuals, that rare individual, who will have side effects. So and this is an example I show for the flu vaccine within our facility, total vaccinated. You can see so many people refuse to, and I don't understand. Of course, there are many theories, depending on your socioeconomic, racial mix of your population, etc., and what has happened with the medical environment and research and disparities, etc. I know all of that, but I knew back then vaccinating alone is not the strategy, because I think infection control will stand ground above vaccination strategy. Next slide. So is testing the best strategy, as people have been so bombarded, where to go, how to get tested? One has to have an idea what, rate of false positive, false negative, timing of test, follow-up, all of this has to be taken into consideration. So I don't know if testing is either also the best strategy, but that's what we have today, right? So, but as a provider, one has to interpret the test properly. I think that's the message I want to send with this slide. Next slide. So then what is the alternative strategy? Well, I've always wondered, should dialysis facilities have installation of airflow and HEPA filters and reverse airflow? I think this is coming. This is the future. I would like to see facilities have that, so respiratory illnesses can be curtailed. Cleaning between shifts is absolutely important, and validating that what is cleaned is good, not just pretending to clean. So all of these are important to do proper infection control measures. Next slide. So, you can have success if you plan ahead, if you are kept up to date with the knowledge, and don't lose that knowledge. Come back and strategize, sit with your team, collect the data, be honest with the data, you know, and seek the help of statisticians to realize what might work and what might not. So what I say is, it did not take a village. It really took the whole world to work together. And what comes out of this is really keeping an open mind, working in a team, and being supportive of each other. Educating the patients and staff will lead to success. Next slide. And I think that's all. I hope I'm within time. If I'm a little bit late, I apologize.
Oh, great. Perfect timing. Thank you. Again, as a reminder to the audience, if you have any questions for Dr. Saggi, please submit them either via the chat or the Q&A. But we do have, I do have a couple questions, and we do have some time, so I'll jump right into them. Dr. Saggi, do you know, or do you have any recent data, or is there any recent data out there about, you alluded to the dialysis units just being such a, almost a, so vulnerable clinics, the proximity, the contact, the many contact points we have. Is there any data out there that suggest how many patients have died, dialysis patients have died from COVID since the pandemic started?
Yes, the data is available, and then actually it was presented by the ASN COVID task force. Apparently about 30% mortality rate is very high in ESRD patients. The actual numbers, because of the restriction of some data, we cannot share all of the data. We can only tell that CKD ESRD is very high risk. The overall mortality, is anywhere between, so there's variation, right? So anywhere between 3 to 15%. This is what we are seeing, or patients may have died of COVID. The 30% number, it looks a little bit exaggerated, but that was early on, when early implementation measures, and we didn't have medications available, which we now have. So the 30% was early on, and then it sort of dwindled down to in that range.
Okay, right. Thank you. Another question here. You as a nephrologist, how did you have those, what kind of conversations, or what did you use to persuade the dialysis patients to get the COVID vaccine?
We are trying to convince them COVID vaccine is by New York City and state rules is given. I don't administer COVID vaccines. I convince them, I can speak to them. So I guess the question is asking how do I convince patients to get vaccinated anyway, right? Not
Yeah.
only COVID, but maybe even flu. Um, and that's been my biggest challenge, honestly, with the type of population I work with, because they already have set in the mind that they were exposed to experiments in the past, and the medical societies and the physicians lied to them. They did not reveal to them what would they get. So there are a lot of history behind it, right? I just, I usually tell them, if they really ask me, some of the patients are very smart, right? They say, "Did you take it, right?" So, so it's so so I say, absolutely yes. I was fortunate. I was called in, and I had to take it, and I will take it again if I have to, because it is protective. Oh, then the next question comes up is, oh, side effects. So, 1 in 1,000, one cannot know the number because these, as everybody knows, this was Operation Warp Speed and it was done very quickly. We don't have data. But the story goes with polio also. So, if I have time to spend with them, I'll tell them, look, the best defense you have is having your T cells or your antibodies in your system to protect you. It's a barrier against the infection, so no one can come in. It's a fence, okay? If you don't want the fence, then anything can come in. It's up to you, but you are at high risk anyway. So it's really speaking to them. And there's no one better than another patient, really, speaking to another patient. That's what I have found, because sometimes we come across as a little authoritative and, in a white coat and all. So I take a backstage. Then I strategize by using patient representatives, and here's where my social workers are very helpful to spread the word. And I know networks have been very supportive of providing educational material in different languages, etc., which is also helpful, telling them the pros and cons and of vaccination. So it's everything, eventually it settles in. Uh, you know, so I don't know. In economics, we're taught when you deprive someone, then they want it more, right? I think sometimes that strategy also works.
Yeah, that's right. Well, that was one of my what was one of the next questions. I'm glad you answered that. It was what kind of materials were you using? So just something I thought of when you were talking. How did the staff receive? How were they receptive to getting the COVID vaccine for for the dialysis staff?
Right. So remember, my presentation is early intervention with infection control, right?
Mm-hmm.
Not so much on early intervention with vaccination because it
Okay.
wasn't available. So this should be actually a separate presentation at some point. But but I can tell you this much, that staff are very instrumental themselves as they approach the patient, because if they have been vaccinated themselves, then they can sell it more, right?
Yeah.
And that's a challenge because the staff themselves may not want to take it because they're hearing mixed. So remember, with the COVID, when it started, all information was confusion, right?
Yeah.
So who do you believe? That's why I put that in, what do? You don't, you're lost in the dark here. You're looking for light and you can't find. But there is light by looking carefully with the information that is seeping in and looking at the pattern or trend. Now you make your conclusions yourself. So,
Mhm.
similarly with vaccinations, you've got to tell them, look, if you don't take the vaccinations, you will be susceptible. And staff, it's mixed, I must tell you honestly, because they have been scared, but as time has passed, they've opted to receive it now.
Mhm. Right. Um, I think one more question. Yeah, one more question here. I know you showed a graph of the percent of patients that received the vaccine. What is that? Can you put that into a number for us?
So we are a small facility, about 200 patients. So if I said this was for flu vaccination, by the way. This is not for COVID vaccine,
Hmm.
okay? This is data is not for COVID. But I put that up as a challenge because I knew this would come in at some point, people would ask, is vaccination the answer to preventing a pandemic? I think infection control will stand the test of time no matter what, because we'll never have vaccine for everything in this earth, right? Something is going to come back again. Who knows? We hope it doesn't. But so the answer to your question is, 200 times 140 may have received the vaccine, and out of that, maybe 50 or 60 refused the vaccine.
Okay.
That's our population mix.
Okay. Not too bad, actually. Probably a little bit higher than I think the average. Well, okay. Well, thank you. I think we're going to go ahead and it's about 5 till you. We'll wrap up. We have just a couple more slides. But thank you again, Dr. Saggi, for presenting today. This was really wonderful information and very interesting. Your story, I love to hear about that. That was really, really nice. And it sounds like your team is really working together to combat the pandemic in your facility. So it sounds like you've got a great team to work with too. So very,
I
very nice job.
I thank you, Stephanie. I thank the NCC. I thank my network for all the support they've given me. And most importantly, I thank my staff and my patients. Um, that's all I can say. I'm privileged to have all the support I'm given, and I'm thankful of it every day.
Yeah. Um, well, yeah. Okay. I did have got one more question came in. I think if you don't mind, real quick.
Sure.
She asked, how many facilities have infection preventionists, and did the infection preventionists have any additional training?
Right. So this was a question that I had within the questionnaire. That's a very good question, and I really wanted to know that. So out of the 16 that responded, they were hedging. This is where I thought there was some bias. They were scared to answer no. And so, I can tell you approximately 6 out of 16, I think between 6 and 8 said they did, so other half didn't. So that's a void that needs to be filled, I think. So what was the second part of the question? Did they have a training?
Did they have any additional training?
So an infection preventionist does need a specialized training. They work within infection control departments, and you can look it up on the CDC. They have what an infection preventionist requires, what training do they require, and they have outlined exactly what they need. Now, there is no special infection prevention specific to the within the nephrology and within dialysis. It's a broad. They do a lot of things. Um, but I think more importantly, I think something new job function that needs to be added to infection prevention is nurses having the ability to collect the data. And most of them are actually trained to do that. And not just one time a direct observation, but ongoing data collection and just putting in the data every day, making observations. It helps root out the problems early on.
Well, thank you for that last minute question. So if I could have the next slide, Melissa. Oh, you had one more there for you. Oh, go ahead, Dr.
Oh,
Saggi. I forgot about that.
I thought
Yeah.
Stephanie, you were going to do this. But anyway, so take home points for everybody, I mean, including myself, is, have the support of your leadership, you know, be kind to them because they may be overstressed than you think that they might not be. And sometimes I wonder whether I want to be in the shoes, right? Two, must keep an open mind, must awareness of new information. You must listen to the news, find time to listen to it, go on the websites and look for, whatever you're used to. If not, CDC will also guide you, your network can guide you. Share the information that you get. Okay, that's very important. I mean, people know me in my facility, in my hospital, and sometimes they say I may be a loudmouth, but I'm sharing information. That's all I'm doing, and I'm having a discussion. I said, do you believe this? Run it by other people, share the information. Okay, and in fact, people will like you for sharing that information. They'll have a healthy debate. Timing of implementation, as I already shown, and I repeated this, was so important, right? Unbeknownst to me, my timing of implementation was really for H1N1 flu, and it helped me for COVID, right? Our patients and staff. Data collection and assessment is very important, and that needs training, honestly, and that needs education. Team effort, I've repeated this, recognition of and support of staff. I think I know this for a fact. If you don't support your staff, you are not going to get anything done. And showing empathy for loss. This is dear to my heart the most. If you don't have empathy, you're finished. You're an empty soul, I think. It just because it's a patient or someone, if you can't send a sympathy card, if you can't do that, I think we've lost all humanity. So I think, that touches my heart deeply. So
Yeah,
okay.
absolutely. Good point. All right, let's go to the next slide. We'll just wrap up. I've got just a few slides. Okay, the next. Just want to real quickly, briefly, not going to take a lot of time, but just as a reminder, we do have a flu vaccination toolkit on our website. Lots of good information for providers, for patients and staff, educational materials, a lot of materials that can be printed. So please visit us and look at the flu vaccination toolkit. Next slide. Again, just some inspirational posters are also available on our website. They are evidence-based. They can be printed and placed in the facilities or your around the clinics. We have them on psychological, physical health, emergency preparedness, and of course, COVID-19. Next slide. And we also have the Kidney Hub. This is a mobile-friendly web tool created with patients, for patients. A lot of information, a lot of resources. You can visit kidneyhub.org today. You can see we have home dialysis, COVID, transplant. We also recently have added the diet and nutritional resources. So please check that out. Next slide. And just as a reminder, our next patient-focused event is March 16th. I just want to do a little plug. This is going to be a panel moderated by one of our patients who's involved with the PAC. The panelists are going to discuss their experiences with the vaccine and why they chose to receive the vaccine. So it should be a good, even though it says patient-focused, if anybody is invited. We also have our next provider event on March 24th. These are all posted on our website. If you're interested in either one, please visit that website to get registered. They should be very good. And the next slide. I think that's it. Thank you. Perfect timing, right at the top of the hour. Again, thank you, Dr. Saggi. Thank you, everybody, for taking time out of your day to join us. And we hope to have you on a future webinar. Thank you, and take care and be safe.
Thank you.
Thank you. Bye-bye now.